My name is Justine Almada. I'm the Executive Director and a co-founder of the HPV and Anal Cancer Foundation. I'd also like to thank Drs. Berry, Van Loon, Chang, and Palandrani for serving on our panel, UCSF and the Farrah Fawcett Foundation for sponsoring this event with us, and all of our co-sponsors, which include UCSF Alliance Health Project, Project Inform, Shanti Project, and IANS. A big thank you must also be extended to Dr. Palefsky, sorry, I say that name all the time, I don't know why I messed it up, for being a leader in the fight against anal cancer. And thank you to Sarah Nelson of UCSF and Cassandra Salmon from the HPV and Anal Cancer Foundation. They were all instrumental in developing this forum. And most of all, I want to thank the survivors who are speaking today, who are on the panel and sharing their stories, and to each and every one of you. You showed up today, some from other states. There are side effects that few people outside our community speak about. You won't find them on any prescription label, and they are the side effects of stigma and isolation. There is a lot of misinformation about anal cancer, about who has it and how people get it, as if the disease and its treatment aren't taxing enough. Once you complete treatment, your social, emotional, and physical quality of life continues to be affected, as we will hear today. I know about the anal cancer experience because my mother had anal cancer. She was a fiercely courageous, beautiful woman who gave everything to my siblings and I. And tonight is incredibly powerful for me because my mother never met or spoke with another person living with anal cancer during the 2 years that she was sick. We quickly learned that anal cancer had few scientific, educational, and support resources. And despite our best efforts, she died from stage 4 disease in 2010. Our mother could still be alive today if the HPV vaccine had been available when she was young, if her gynecologist had a screening protocol, and if her doctors had more therapy options to attack her stage 4 diagnosis. We dreamed of a day when no other families had to face this disease or feel the sting of its stigma. Inspired by Mom's strength and the urgency to prevent this illness in others, my siblings and I started a nonprofit, the HPV and Anal Cancer Foundation. And we made it our goal to end HPV and anal cancer and their stigmas for good. We include ending HPV in our mission because this carcinogen causes 90% of anal cancer and 5% of all cancers worldwide. When we first started, people would say, "You're doing what? You are the what foundation? What kind of cancer?" Or we would just get the blank stare. You know what I'm talking about. And today, we are sitting in the largest gathering of survivors ever. We have come, we have come so far. Thank you to everyone in this room for helping to make that happen. Now, there is a routine vaccination for men. There is IANS, the Medical Society. Anchor, the first study to validate anal cancer screening methods, and that's just getting started. And there are researchers working on novel therapeutic approaches to target HPV-related cancers. We hope you will join us as we continue to transform the anal cancer experience. To change the landscape, we must work to increase access to the HPV vaccine, work with the government and researchers to ensure they have the tools they need to communicate and prevent and treat this disease, and we work to support survivors. As the name of this forum indicates, we are all here to ensure that everyone thrives. To create connections between survivors, we just launched a peer support program that will match survivors with each other, and you may have heard Cassie speaking about it as you came in. We're looking for volunteers to offer support to others, as well as participants who would like to receive support from a peer. There's information in the handouts, and we encourage you to sign up to help bring this community together. With the help of the doctors, like the ones here today, we see a better scientific and medical infrastructure in the future that will develop less painful treatments, diagnose the disease in its precancerous stages, and prevent it altogether. Life after anal cancer can be extremely trying and frustrating, but with community support, these obstacles do not need to define your life. The more time we spend together as a community, and the more people speak out like the survivors and doctors tonight, the louder our collective voice becomes. I look forward to hearing the individual experiences from each of the survivors on the panel and from all of you. I hope you will stay to meet each other after tonight and reach out to us if you would like to get involved in building this community. In that spirit, before the next speaker, I would like everyone to take a second to introduce themselves to their neighbor. Go ahead. Thank you so much for doing that. I'm going to turn it over to Chang.
Thank you, Justine. So we're going to have brief presentations by our distinguished panel, and the first of those is Albert Chang. He's an assistant professor of radiation oncology here at UCSF. He specializes in radiation therapy for the treatment of genitourinary malignancies, gastrointestinal malignancies, and gynecologic malignancies. He has expertise in modern radiation techniques such as stereotactic body radiotherapy, cyberknife radiosurgery, brachytherapy, and intensity modulated radiation therapy. A lot of handful of words. Dr. Chang received his PhD in molecular medicine and his MD from Boston University School of Medicine in 2007. He did a radiation oncology, residency in radiation oncology at the Washington University School of Medicine. His research interests are in the development of molecular imaging probes and targeted therapies. He has developed multiple imaging agents with the ability to characterize tumors at the cellular level, and these imaging agents have the potential to be used for defining the extent of disease, for predicting treatment response, and for optimizing therapy. These are all good things. He's also involved in the design of clinical trials investigating advanced imaging technologies, radiation therapy techniques, and targeted drug therapies that allow for the maximization of the therapeutic effect while trying to minimize treatment side effects. So with that introduction, I'd like to ask Dr. Chang to come and say a few words to us. Albert?
Thank you for inviting me to speak today. It's really it's a pleasure to meet all of you today and kind of show what we're doing here as a team at UCSF and also in radiation oncology. So usually I begin my presentations with a case, that I've treated in the past, and it's just to bring us, I guess, to something that we can be familiar with. So my patient was a 65-year-old female who presented with perianal pain, lower GI bleeding, and was anemic, had bleeding resulting in a hemoglobin of 7. So when she came in on exam, we saw that she had a large 6-centimeter mass protruding through the anus and a bulky right inguinal lymph node. So our next question when we see our patients is, how do we manage our patients? So just to give you an overview of what I'm going to briefly speak about today, I'm going to go over the anatomy of the anal canal, the treatment, side effects, and how we have strived to improve some of these side effects in treatment. So the anal canal is about 3 to 4 centimeters in length. And it usually starts from the non-hair bearing skin. That's what we call the anal, the initiation of the anal canal, and it's about 4 centimeters. On exam, we can feel it as ring, kind of and that's where it usually ends. So patients usually present with rectal bleeding, pain, or some of the patients have serial screening, which Dr. Berry will talk to you about for pre-malignant lesions, and we'll find anal cancer in them. At initial presentation, most patients have early disease, small tumors, less than 2 to 5 centimeters. About a third present with positive lymph nodes, and less than 10% have metastatic disease. So the initial workup for our patients include a detailed history and physical exam. And we usually have our patients undergo an endoscopy proctoscopy, which Dr. Berry will talk to you later about, and routine labs including a complete CBC with differential and HIV screening. Also, in all our patients, we get a PET CT scan, and talked about imaging as my area of research interest. PET CT is very, very sensitive for detecting sites of disease, especially distant metastatic disease and nodal disease. That's why we get it. It's about 90% sensitive. So here is the same patient that I initially presented. You can see this is looking at a pelvis view, and this is the area that's very bright on the PET scan, telling us that this tumor is active. And also in the right groin area, you can see a lymph node that's also showing up. That's why these scans are very useful. So talking about the old days, well, I like to give some history in my talks. So back prior to the 80s, talk about advances back before the 80s, the standard of care was to do a pretty big surgery where they would remove the anus, the rectum, and all the lymph nodes. It was a pretty morbid procedure, and it resulted in a permanent colostomy. But in terms of recurrence rates, still about a third of the patients were recurrent. So this guy, Norman Nigro, actually back, I think in the 80s, early 80s, started, how can we improve the outcomes of surgery? Why don't we add chemoradiation treatment? So at that time, they added chemotherapy, what we use now, 5-FU and mitomycin C, and a low dose of radiation. And all these patients went to surgery, but at the time of surgery, about 84% of these patients had no evidence of disease. So it showed us that chemoradiation really worked to eradicate the disease. So here's there's survival. A lot of the people that had no evidence of disease after chemoradiation, there was about a 90% survival rate. So they, at that time, stated that that should be the standard of care, just definitive chemoradiation, omitting the surgery. So that's how there was other subsequent large studies that validated these findings, and it became our standard of care, what we use today in the clinic. We give chemotherapy twice during week 1 and week 4 with 5-fluorouracil and mitomycin C, and also we give 5.5 weeks of radiation therapy, anywhere from 28 up to 30 treatments. So looking at characteristic factors to help, I guess, prognosticate the outcome, there were several studies that were done. In general, they saw that females had a higher risk of recurrence. Tumors that were greater than 5, actually males have a higher risk of recurrence, sorry. Tumors greater than 5 centimeters also were likely to recur. And we see that about 30% recurrence in patients that have tumors greater than 5 centimeters. This is across the board for multiple clinical trials. And also having positive lymph nodes was a bad prognostic factor. Going into the toxicity, that's what we're here to talk about. With chemoradiation therapy, you can see this is during the treatment, there was a high toxicity rate, 60% grade 3 to 4. These are pretty significant toxicities, medically significant grade 3, requiring hospitalization, or grade 4 life-threatening complication requiring urgent intervention. And a lot of these toxicities were skin toxicity, GI toxicity like diarrhea, significant pain, or drop in blood counts, 25% of hospitalizations and 5% that were life-threatening historically. So as I mentioned, the standard of care was 5-FU mitomycin C. So there was a trial that was done in the UK looking at how can we decrease the toxicity, especially the blood toxicity, the drop in counts during the radiation treatment. So they looked at substituting the mitomycin C that I was talking about during weeks 1 and week 4 with cisplatin. So this trial compared 5-FU mitomycin C with 5-FU cisplatin. And they saw very, very similar outcomes in terms of controlling the primary tumor or controlling metastatic disease. However, what they saw was a significant improvement overall with decreasing the hematologic toxicity, the drop in blood counts. And this is pretty important. Also, how else can we improve? Our radiation techniques over the past 20 years have significantly improved. Historically, we would give these big, wide open fields that would, treat everything in, that it encompasses the bladder, the pelvic bones, which can also cause a drop in your counts, the anus, the rectum, and such. So now, now we can use intensity modulated radiation treatment. This is what I routinely use in the clinic. And we can sculpt out the doses to the areas of involvement that we see. Here was the anal tumor, and here was the lymph node that you saw in the PET scan. And we could really sculpt out the dose. The red is our prescription dose, our hot dose. And here is our elective. We have to treat elective lymph nodes that are at high risk. But you can see that we're able to spare a lot of bone, the remainder of the skin and such. So using IMRT, there was a large clinical trial that was run through the Radiation Therapy Oncology group, which we participated in here at UCSF. And there was a significant improvement in toxicity, GI toxicity, skin toxicity, and what isn't shown here is now the data is coming out for improvements, long-term improvements in sexual, sexual dysfunction, and you see improvements in sexual dysfunction of intensity modulated radiation therapy. Last thing, I mentioned earlier on about the prognostic factors. Remember, I mentioned that tumors greater than 5 centimeters were more likely to, recur locally. So here at UCSF, we're working on developing a technique where we can even give higher doses of radiation to these large tumors, just locally into those areas while minimizing the dose to the other surrounding normal structures. And in that way, we can reduce toxicity and make our treatments more applicable. So I always like to end my talks with a happy ending, and here's my happy ending. You remember this scan, pre-treatment, afterward, you see no evidence of disease. Here was the same patient, pre-treatment, really big tumor, and post-treatment, it's all gone. Yeah. So how do I follow up my patients? I do routine physical exams, and I do a digital rectal exam at each physical exam. Usually 6 weeks out, I see my patients, and every 3 months thereafter. If the patients, one of the things I didn't mention is the patients have a lot of skin toxicity during the treatment. The skin breaks down in the groin and the perianal area, and we like to see our patients daily, even weekly, and after the treatment to follow up and manage. We have a great nurse who's sitting right back there that helps a lot with our skin care. She's great, Ludine. Yeah. And we on the exam, if there's any question of persistent disease, we follow it. And this is one thing that's really important, because 3 months out, 6 months out, the tumors will continue to respond, even after a year. You only biopsy the tumor start growing. And Dr. Barry will talk to you later. He helps me out a lot with doing the anoscopies as part of the surveillance. Okay. Thanks a lot.
Thank you, Albert. It reminds me of one of our colleagues who we trained in South Florida, who's an anal surgeon, and he has a clinic that he calls the Happy Heine Clinic. I was really jealous that he got that before we did. Continuing our brief presentations, we're next going to hear from Katherine Van Loon, who is an assistant clinical professor of gastrointestinal oncology. She's a medical oncologist. Dr. Chang is a radiation oncologist. Dr. Van Loon received a master's degree in public health, an MPH, from Yale, and attended the Medical College of Georgia. She completed her residency in internal medicine at the Beth Israel Deaconess Medical Center in Harvard, and a fellowship in oncology here at UCSF. She received a Young Investigator Award from the ASCO Conquer Cancer Foundation in 2012. She's a medical oncologist here at the UCSF Helen Diller Family Comprehensive Cancer Center, focusing on the management of gastrointestinal malignancies. And that, of course, includes anal cancer. With her background in public health, her research is focused on the epidemiology and outcomes of gastrointestinal malignancies. She's particularly interested in lifestyle issues impacting survivorship and the personalization of surveillance strategies. So please welcome Dr. Van Loon.
Thanks very much for having me, and welcome. I was asked to give a little bit of my perspective today on how I care for patients following completion of treatment for anal cancer in the context of my medical oncology clinic. And Albert gave a very comprehensive review of how we treat patients, and I want to talk a little bit today about life after anal cancer. I'm going to just give a few slides of background for the sake of interest, and as I reflected on the fact that there are so many of you here today, I wanted to point out how rare of a disease this is. Anal cancer, in terms of all of the cancers that we treat here in the Cancer Center and nationwide, is the 26th in terms of incidence. In 2014, it was estimated that there would be approximately 7,200 new cases of anal cancer, and an estimated 950 people will die of this disease. Survival after anal cancer is pretty good. In terms of the diseases that I treat, it's one of the best, with approximately 65% of patients, or 2/3 of patients, making it to 5 years following completion of treatment. This number is, of course, variable based upon disease stage at time of diagnosis. 65% still isn't good enough, and just as a sobering fact, here you can look at the time trend, that in fact, going back to 1975, the 5-year survival was 65% even then, so we haven't made much improvement. So these are the topics that I'm going to touch on today. What happens after completion of treatment? Surveillance is really important as a medical oncologist, and we follow our patients out to 5 years after completion of treatment. Long-term toxicities include bowel dysfunction, changes in bone density, and sexual dysfunction. And then the question that I hear all the time is, what else can I do, doctor? Fear of recurrence is an issue that's particularly important to me, and is something that I think is very pervasive in the growing number of cancer survivors that we see here in the Cancer Center. Dr. Chang touched on this, but this is an overview of the surveillance guidelines from the NCCN, and I put this up here to just show you how vague they are. So for a patient who is in complete remission after completion of treatment, it's recommended that every 3 to 6 months for 5 years they undergo a digital rectal exam, anoscopy, inguinal lymph node palpation, and then that we think about a chest, abdomen, and pelvis CT annually for 3 years. In practice, that is not necessarily what every single one of your medical oncologists and radiation oncologists does. Typically, we look after about 3 to 4 months with a PET CT scan, and we're very, very vigilant about looking for early evidence of persistent disease, because that definitely stratifies how we follow patients going forward. The long-term toxicities of chemoradiation to the pelvis, as I mentioned before, bowel toxicity, decreased bone density, and sexual dysfunction. The acute toxicity is typically a little bit different than the long-term bowel toxicity. Acute toxicity can include diarrhea, rectal urgency, rectal frequency. Acute toxicities from chemotherapy often include low platelet counts, low white blood cell counts, as well as enteritis, which is inflammation of the bowel due to radiation exposure and chemotherapy exposure. Dysuria can indicate that there are some acute risk of genitourinary symptoms. The risk factors for long-term bowel toxicity are the radiation dose, the volume of bowel that's irritated, the fractionation schedule, the concomitant administration of chemotherapy, and then patient factors. So any patient who has had prior abdominal surgery is at a higher risk for bowel toxicity, and pre-existing vascular disease, as seen in patients with diabetes or cardiovascular disease, is also a risk factor for worse toxicity. Bowel symptoms can be variable in terms of when they occur. They can occur any time from 6 months after completion of treatment to 25 years after completion of treatment. The average is 2 to 3 years. And they include abdominal cramping, alternating diarrhea and constipation, malabsorption, bleeding, and in rare cases, obstruction or perforation. This is data that's extrapolated from patients with rectal cancer, a disease that also is treated with radiation exposure to the pelvis. We know that these patients are at high risk for osteopenia, which is decrease in the density of the bone. And in approximately 77% of patients who undergo pelvic radiation for rectal cancer, insufficiency fractures can be seen in the sacrum, the pubic rami, and the femoral neck. So I tend to recommend that patients who have completed pelvic radiation are followed routinely with bone DEXA scans to monitor for evidence of osteopenia or osteoporosis. The third category of late effects is sexual dysfunction, and I'm going to just touch on this because I believe one of the speakers after me is going to go into it in more detail, but I typically see this as an issue that comes up very frequently in surveillance visits with my patients. Women experience early menopause, infertility, vaginal stenosis, and vaginal dryness, and men also experience infertility and symptoms of hypogonadism. In terms of my recommendation for managing the chronic gastrointestinal toxicities, there's a variety of things that can be tried. None of these works for every patient, and none of these has been studied in a randomized controlled trial, but patients anecdotally do benefit from lactose-free diets, adjustments in fiber intake. A BRAT diet is a medically bland diet, probiotics to replace the bowel flora. Antibiotics have improved symptoms in some patients, and in some patients oral steroids can be useful. And in extreme circumstances, just a trial of bowel rest and other forms of nutrition can be useful. For bone density loss, I recommend vitamin D and calcium supplementation. Exercise is important as we get older for all of us, even without a history of radiation therapy, to improve our bone density. And then engagement with primary care physicians for routine screening for osteopenia and osteoporosis. So I hear this question a lot: what else can I do, doc? And there's lots of things that we understand are modifiable risk factors, both in terms of preventing cancer, but also in terms of preventing recurrence of cancer. I bring this slide back up. Anal cancer is a really rare disease, and none of this has been studied, particularly in patients with anal cancer. So the slides I'm going to show you subsequently about how I generate recommendations for patients with anal cancer are extrapolations from other diseases that are more common, and which we've been able to study these in a rigorous fashion. There's growing data from patients with breast cancer, colon cancer, ovarian cancer, and prostate cancer that diet actually really impacts disease recurrence. For patients with breast cancer, more than 5 servings of veggies and fruit per day plus 30 minutes of exercise means patients are 45% more likely to survive 10 years. Patients with BMIs of less than 30 are at lower risk of distant metastases after 10 years. In colorectal cancer, which is possibly the closest disease that I can extrapolate from, we know that non-Western dietary patterns, which means a diet that's low in red meat, low in processed grains, low in fat, and low in sweets is 230% more likely to mean that patients are alive at 5 years after completion of treatment. In ovarian cancer, similarly, we know that more than 5 servings of veggies and fruit per day means that patients are more likely to have survival at 5 years. These are the AICR guidelines for cancer prevention. They recommend choosing mostly plant foods, limiting red meat and avoiding processed meat, being physically active every day in any way for 30 minutes or more, aiming to be a healthy weight throughout life, and avoidance of smoke and tobacco. Their final guideline is that after completion of treatment, cancer survivors should follow the recommendations for cancer prevention. So all of these rules apply. Why do we think that physical activity and obesity affect cancer risk? Physical activity decreases inflammation, it reduces levels of circulating sex hormones, it protects against insulin resistance, it decreases gut transit time, and it induces enzymes that protect against oxidative stress. Obesity, conversely, increases the inflammatory response, increases circulating estrogens, decreases insulin sensitivity, and increases circulating insulin and leptin. So this slide is just a basic summary of my recommendations for my anal cancer survivors who I follow in my clinic. As per the NCCN guidelines, I recommend 5 years of medical surveillance after completion of therapy. And that is, these guidelines are vague. And typically the imaging practices depend upon the patient, the stages of disease at presentation, and our general sense of the patient's risk for recurrence, balanced against the risk of repeat radiation exposure from surveillance imaging. For exercise, I recommend, according to the American College of Sports Medicine guidelines, 150 minutes a week of moderate aerobic activity and strength training 2 to 3 times per week. Dietary modifications and bone health surveillance with calcium and vitamin D supplementation. So we all know what to do, and you probably aren't hearing these recommendations for the first time. What are the barriers, and what things prevent us from executing these things? Too little time, too little sleep, too much effort, too much food, too much eating out, too much stress, too much anxiety. We all experience these things, cancer survivors or not, and we all confront these issues as we move forward. I bring up fear of cancer recurrence because it's become a research area of interest of mine, and it's something that has been pretty well validated in other cancers as something that negatively impacts cancer survivors' ability to execute the dietary and lifestyle changes that physicians and caretakers recommend. So cancer naturally leads to a fear of cancer recurrence. Every time one undergoes surveillance imaging, this becomes a very, very pervasive part of the cancer survivor experience. And it can, if it, in the negative context, lead to experiential avoidance, where patients can attempt to avoid the feelings of fear of cancer recurrence through reassurance-seeking, rumination, body monitoring, and or withdrawal. It can increase cancer recurrence fear, utilization of negative coping mechanisms, distress, and life disruption. And in fact, it can decrease our ability to execute values-driven behavioral changes and embracing the dietary and lifestyle recommendations that are recommended. And I bring this up because I think it is a really important topic for patients, especially those of you who are meeting other anal cancer survivors for the first time, to be able to share with one another, because it is something that you independently live with that very few other people who are not cancer survivors can ever understand. My final slide is about hope for the future. So therapeutic advances, and we've alluded to the fact that there is a robust vaccine prevention study that is ongoing. Vaccine therapy for the treatment of anal cancer is also an area of interest, and there is ongoing research into DNA vaccines and therapies to generate cellular immunity against HPV-infected cells.
Thank you very much, Katherine. So it's now my pleasure to ask Allison Palandrani to speak to you for a few minutes. Allison received a bachelor's degree in exercise science from Sonoma State University and a clinical doctorate in physical therapy from the University of Southern California. She's a physical therapist who specializes in pelvic floor dysfunction and treatment at the Pelvic Health and Rehabilitation Center in San Francisco. We asked her to come talk with you because many of our patients recommended her as the go-to person for having pelvic pain. She's an active member of the International Pelvic Pain Society, and she's involved with community outreach and education in the Bay Area. Thank you very much for coming to talk to us today.
Okay. Hi, my name's Allison Palandrani. Like Dr. Palefsky said, I am a physical therapist, and I wanted to talk to you about how we can manage some of the long-term side effects that we see with chemoradiation therapy, specifically with anal cancer. So just a quick about me, I'm a physical therapist, like I said, at the Pelvic Health and Rehabilitation Center. We have 4 offices, San Francisco, Berkeley, Los Gatos, and Los Angeles. And there's 8 PTs that practice throughout those offices. And we all are pelvic floor specialists, so we only treat issues that are concerning the pelvic floor, specifically pelvic floor muscles. So some of the long-term symptoms that are associated with chemoradiation therapy, specifically in anal cancer, are going to be pain, hip, pelvic pain, surgical pain if there was a surgery performed, fatigue, which can be a long-term or a short-term side effect, lymphedema, general musculoskeletal concerns, which we'll get more into towards the end, and then pelvic floor dysfunction. So how can we help? How can physical therapists help you manage symptoms, side effects after anal cancer treatment? Well, I think there's a big role for rehabilitation to help manage these symptoms. There's virtually nothing in the literature. However, I think there's some good clinical evidence that we see just as practitioners. So pain. Pain can occur because we've gone through radiation. There's permanent damage to some of those tissues. And it can also occur because we change our movement patterns and some of our physical functions because of the cancer treatment. So things that we can do are, as physical therapists, we can do manual therapy to treat areas that may have myofascial trigger points, so that's going to be like a knot in the muscle, connective tissue dysfunction, any scars that may be there and adhered, and then working with the joints as well. We can also address, like I said, movement dysfunction that we may be seeing. We talk about posture, seating, what you should be seating on, cushions, gait, and then issues with the lumbar spine, the pelvis, or the hip. Fatigue is an issue, like I said, it can be a short-term or a long-term side effect of chemoradiation therapy. There was a Cochrane review in 2009 that found that exercise was statistically more effective in relieving symptoms of cancer-related fatigue than the control. The control did not exercise. And then Stricker, there's a study by Stricker in 2004 that found that moderate levels of exercise or physical activity were shown to help relieve some of the effects of cancer-related fatigue. That study also mentioned that if individuals feel that they're becoming weak or deconditioned, they should be referred to rehab to maximize their functional status. Because as we just said, exercise is something that we should be doing lifelong. So PT can help with planning out your day, pacing the physical activity, because it's not something that we want to be pushing through. It's something that we want to be kind of working with and managing. Lymphedema is something that we can see post-chemoradiation therapy. So things that we can do to help and that you can do at home as well are manual lymphatic drainage, always looking at the skin integrity, compression and fitting for compression garments, exercise programs to help manage that lymphedema, and then maintenance programs to make it as best as we can and kind of maintain that level. So general musculoskeletal concerns that we see, muscle weakness. So radiation is going to damage the tissues that it touches, and it can cause, permanent muscle weakness. We can see neuropathies from the chemotherapy, and then we can see just kind of general deconditioning again. So we need to help create sort of optimal exercise programs to create better movement strategies and just better kind of quality of life for some of the changes that are associated with chemo and radiation. So pelvic floor dysfunction is the big one, and when we're talking about anal cancers, it's something we see a lot and what I treat a lot in my office. So we see commonly anal canal and vaginal canal stenosis. That's a narrowing of those canals. We can do manual therapy to help maintain the patency of those canals or the openness. We can also work with you to use dilators at home to kind of have a progressive program to maintain patency. Gas and fecal incontinence is something that's really common, and so we can work to strengthen the pelvic floor muscles as well as we can, work on endurance, motor control, motor planning. We can also, to help with some of that pelvic floor muscle function, we can use biofeedback or neuromuscular electrical stimulation. We can also help with management of those symptoms. Sexual dysfunction is another issue that we come across pretty frequently, so pain and erectile function. We had better luck managing the pain. There's one study that was out on actually post-prostate cancer and erectile function, and it found that strengthening the pelvic floor muscles helped with erectile function. So what you can expect if you were to come into pelvic PT, we would want a thorough medical history and explanation of your symptoms, what you're experiencing. We would want to do a structural and biomechanical evaluation of you, so we'll watch you walk, sit, stand, look at the joints, look at the pelvis. And then we would have you undressed from the waist down, and we would do an external exam because basically the muscles and tissues from your ribs to your knees can be affected when we've gone through chemoradiation therapy for anal cancer. So we're going to want to evaluate all of those tissues, and then we're going to want to do an internal exam per vagina or anus, or both. And so we're going to, in that way, evaluate the strength of the muscles there, the muscle tension, the motor control. We're going to want to palpate the nerves, and then the tissue integrity as well. With all PT, you can expect some kind of home program to be doing some things on your own to help with what's going on. So physical therapy would be appropriate after you've been cleared from your physician. Anytime post-surgical, post-radiation, if you're having pain, which people commonly are, and that's lower abdomen, groin, vaginal, anal, genital, or scar pain, common what we see. Any bowel bladder dysfunction, so incontinence, constipation, urgency, frequency, pain with bowel movements, and sexual dysfunction, pain or erectile function. So just implications into the musculoskeletal system after chemoradiation therapy, and this is what we're treating. It's going to be pelvic floor muscle hypertonus or tension. Sometimes that insult to the tissues can cause our muscles to guard and just hold tight. That can contribute to constipation, incontinence, can contribute to sexual dysfunction as well, and urgency and frequency. We can see pelvic floor muscle weakness sometimes, which can contribute to incontinence. Neural irritation, especially from chemotherapy, which can cause pain and erectile dysfunction. Abdominal muscle dysfunction. Scars, if they're present, can cause pain and hypersensitivity. And then the overall deconditioning is something that we really want to address as well. Oops. Okay, so the role of pelvic physical therapy in management of some of the long-term side effects that we see after treatment for anal cancer. Like I said, I think there's a big role, and I think there's a lot of help that can be had. So we can normalize some of the pelvic girdle and pelvic floor muscle tone, strength, and motor control. We can get rid of the trigger points, which are like knots, improve the fascial mobility, improve any structural biomechanical impairments that are present, help you develop and manage an exercise program, and then help to educate you on what's going on and what you can do yourself. So I just put on here a couple links of how you could find a pelvic physical therapist if that was something you're interested in. The International Pelvic Pain Society has a spot on their website that lists PTs by state. The American Physical Therapy Association, they have a thing called the section on women's health. I don't know why they named it that, but many of the therapists on that website treat men and women. And then I just put my website up there, pelvicpainrehab.com, because you're welcome to call and ask us if you have any questions. So again, my email address is up here. Feel free to email me if you ever have any questions, but I would be happy to answer them.
Thank you very much, Allison. So our last speaker before we hear from our survivors is Michael Berry, who is a clinical professor of medicine here at UCSF. He's in the division of HEMONC because he's a medical oncologist by training, and graduated from the University of Miami School of Medicine and was resident in internal medicine at UCSF and did his oncology fellowship at Stanford. The UCSF Anal Neoplasia Clinic was the first in the world devoted to the prevention of anal cancer. And we founded that around 1990 or so. And the very first person to join me in that after I founded the clinic was Naomi J. Where's Naomi? In the panel. Most of you know Naomi. And when Naomi had the temerity to go and have a kid, to replace her, and Michael happened to be available at the time. And so Michael joined us soon afterwards, and without these two individuals, we couldn't have done nearly as much as what has been accomplished. They've been with me every step of the way, and they're absolutely invaluable. So Michael is, along with Naomi, is the Associate Director of our Clinical Research Studies, and is the co-principal investigator, along with me, of the ANCHOR study. And he's devoted his life, like the rest of us, to anal cancer and its prevention. And he's going to talk to you tonight about what we do in the Anal Neoplasia Clinic. Michael.
Coming, I see many familiar faces, and it really warms my heart to see everybody here. I want to thank our sponsors for making this possible, and hopefully this is the beginning of this community that we're establishing that will continue long beyond this. So I'm going to talk about long-term follow-up after completion of therapy for anal cancer. A lot of what I have to say has already been said, but I'm going to concentrate on why it's important and how we do it in the clinic. And then I'm going to share a few words on treatment for early anal cancer without radiation and chemotherapy, and then end with a slide on hope and promise for the future. So the reason that we do long-term follow-up is, one reason is to detect cancer spread to other parts of the body. You know, as you heard from Dr. Chang, that doesn't happen very often, fortunately. The other thing we do is we want to maximize your chances of cure. So what we look for is persistence. Does the treatment get rid of the cancer? Early recurrence? Did the cancer come back? And then we look for precancerous lesions, what we call high-grade squamous intraepithelial lesions, or HSIL. And we look for these because we think that by finding these and getting rid of them, that we can prevent the development of either local failure or possibly even second cancers. So just a little bit about anal anatomy. I'm not really going to say too much about it. Let's see. So this is the lower part of the rectum, and it joins to the anus. Everybody says, oh, I've got rectal cancer. Well, most of the people, when they say rectal cancer, most people confuse that with the anus. The anus is just the opening, and the opening serves as literally a door or a trap door to kind of keep the poop up in the bowel and to open the door when it's time to have a bowel movement. So it's lined by muscle, and that muscle is kind of what limits most of our treatment, causes a lot of our problems, and is hugely important to quality of life. So you've seen the NCCN guidelines, so I'm not going to really kind of spend a lot of time talking about them. But again, focusing on what we like to call digital anal rectal examination to distinguish it from DRE. And what we're trying to point out here is that in medical school, many people are taught to stick a finger up the butt, and that's called a DRE. But what we really want people to do is to do a digital anal rectal examination. We want physicians who care for patients at risk for anal cancer to very carefully palpate the walls of the cylinder, 360 degrees. And by doing that, we can sometimes find very subtle abnormalities or very early presentations and recurrences of cancer. And it's amazing the number of people that come to us with a diagnosis of cancer who've never had an examination before. So I know it's one of the missions of the HPV and Anal Cancer Foundation. It's certainly our mission as well, too. Feel for nodes in the groin because that's one of the prime easy places that they can spread. They recommend specific imaging for larger tumors, that is what we call T2 and greater than 2 inches or 5 centimeters, and if the groin lymph nodes are involved. So what we do in the anal neoplasia clinic is everybody comes in and gets a digital anal rectal examination, as I mentioned, a very careful palpation of the muscular walls. We actually precede that by doing an anal cytology specimen, because you've got to do the swab first before you put any lubricants or numbing jelly up there. And then we follow that with high-resolution anoscopy. And this is definitely different than what the NCCN guidelines recommend, and is unique to the anal neoplasia clinic. Anal cytology is similar to what women get in terms of a cervical pap smear. It's a gentle scraping of the walls of the anus to kind of remove any abnormal cells that are there. The way we do anal cytology is a double check on what we see. High resolution anoscopy is where we put vinegar in the anal canal and look with a microscope. It allows us to find lesions that are otherwise invisible. Is, we feel, a very important way of finding these precancerous lesions. There's not much published on this in terms of looking at recurrence of disease. I'm going to talk a little bit about that in another slide. I examine patients every 3 to 4 months after completion of radiation, and then every 4 months for the first 2 years. The reason that we're concentrating more frequently in the first 2 years is because that's when the greatest number of recurrences occur. So it's estimated that about 85% of recurrences, if they're going to occur in the first 2 years, and then an additional 10% in the next year. So by 3 years, more than 95% of the recurrences have developed. So after the second year, people graduate, and then we see them every 6 months for 3 years, and then we continue to see people annually. We do find that PET CTs or CT scans, if insurance doesn't allow us to do the PET CT annually for the first 3 years, is useful. And tend to pay less attention to exactly what the stage of disease is. Particularly as we're treating some of the early cancers, I think we're finding some discoveries of things that we weren't expecting to find. So what happens if the digital anal rectal exam is abnormal? Well, as Dr. Chang had mentioned, as you finish the radiation, you continue to see effects of the radiation for well up to 6 months, if not even longer. And so what we want to make sure is that if there's any abnormality felt there, that it's getting smaller, that it's not growing. If it's getting growing, then that's a concern, and that's when we want to do biopsies. One of the reasons that we avoid doing biopsies early on, or to prove that the cancer has been cured, is because we found with some earlier studies that a lot of people didn't heal very well and developed very large non-healing ulcers. So we want to avoid that as much as possible. Those biopsies are to be distinguished from the very little biopsies that we do in the anal neoplasia clinic. So what we do is very tiny, just a couple millimeters, less than a fraction of an inch, and nobody ever develops deep ulcers from our biopsies. If the cancer is getting bigger, if what you feel is growing after treatment or comes back as we're doing these serial exams, then you have to do a biopsy. We try to do a biopsy in the clinic if at all possible, but if we can't make a diagnosis, then we certainly take patients to the operating room and help the surgeons find the areas that we're interested in. If cancer has come back, it's been biopsied, then additional tests, the staging that Dr. Chang and Dr. Van Loon mentioned is done. And if it is not spread, then there's a second opportunity for cure. And that's when the anus is removed completely and the end of the bowel is brought out to the abdomen, something we call an APR colostomy, which was, if you remember going back to the old days, that was what used to be done before radiation and chemotherapy. So, in addition to the anal exams, we recommend that women should continue with regular gynecologic exams looking at the cervix and the vulva. So when we think of HPV infection, we think of an anogenital field effect. So that oftentimes many of the women that we see with anal cancer have had prior earlier problems in the cervix or in the vulva. The second point where I say if anal cytology is abnormal, then HRA should be formed, sort of refers to people who might not have access to our clinic, who are being cared for in other parts of the country where they might be able to get an anal swab done, but they might not be able to get HRA. Certainly, if any abnormal cells are seen, then people should be referred someplace where HRA can be performed. We biopsy any abnormal areas that we see. If we find HSIL, then we treat those areas carefully using the same techniques that we would use if somebody hadn't been radiated. We see these changes occur more often in people that have HIV infection. And as I mentioned, if a biopsy is suggestive of cancer, but we can't make the diagnosis, then we return to the operating room for a bigger biopsy. Naomi has put together some of our data from the clinic on how often we find disease, looking at about 70 patients or so, and looking at what we've seen in terms of following people after radiation. And in that group, the women have done amazingly well. They're a relatively small group, about 20 women or so. But only one of those women being followed has had a recurrence of HSIL, and we've seen no recurrence of any of the cancers in the women that we've seen. The men have not done so well. Most of the HIV-infected men, about 20% will have high-grade disease, and another 20% or so will have recurrence of cancer. The HIV-negative men, surprisingly, they're a much smaller group, so it's a little bit biased in terms of sample size. There were only 16 HIV-negative men as opposed to 48 HIV-positive men. But about a third of them had high-grade disease, and about 13% had recurrence of cancer. So there's an interesting article that was recently published out of England looking at using the same strategy that we use, anal cytology and HRA, and they looked at a small group of patients that have been treated, about 20 patients, and what they showed in comparing to a historical series, that by following and treating high-grade lesions, they felt that the local recurrence in their group was reduced about 6-fold. And suggests that this needs to be studied further, but this is the only published data that exists on this. So I'm going to talk about early cancer now. So what is this? This is a very small cancer that is not felt on DA or E. Often it's found accidentally, either during a colonoscopy, when the endoscopist looks in the rectum and sees something, or possibly doing hemorrhoid surgery. Or occasionally, when we're doing HRA in the clinic, we will focus and target our biopsies in the most abnormal areas, and we'll find some of these cancers. The official name for it is called a superficially invasive squamous cell carcinoma. The formal definition says it can be no more than 7 millimeters, or around 1/4 of an inch in width, and it can only invade a little bit, no more than 3 millimeters, which is about 1/8 of an inch. These superficially invasive cancers are cut out during surgery with a small rim of normal tissue. The reason that we don't take a big rim is because, remember, I showed you the sphincter muscle, and we want to preserve that. And then close follow-up with high-resolution anoscopy and destroying any high-grade lesions is, we think, what is needed when patients don't get radiation. But I'm going the wrong way. And does it work? Our approach is not yet standard of care, but we've had very good results, sparing about 90% of patients from radiation and chemotherapy in about 81 patients. And a study is now being designed to evaluate this approach nationwide. So the hope and promise for the future, I would encourage all of you who have relatives or friends of children that are around 11 or 12, boys or girls, to encourage them all to be vaccinated. And we hope that this will go a long ways towards prevention of anal cancer. Thank you very much.